I think in 2019, a young surgeon, Bo Lu, who's current chairperson of the Asia Pacific Wrist Association, said something that really crystallized. He said, "Don't tell me what's in the literature, I can read." So when we look at an undisplaced scaphoid fracture, we're actually looking at a frozen moment in time. Our CT scan does not give us information about the stability of the fracture, the stability of the carpus, whether or not there's a perilunate ligament injury, and if or not it involves the distal radio-ulnar joint. You have no idea about the displacement of that fracture and that wrist at the time of the injury. Furthermore, the definition of undisplaced fractures of the scaphoid is unclear. So we're having a controversy about whether or not we splint, treat conservatively, or operate on a condition which is not clearly defined. So we're creating a maelstrom. We're creating confusion. So we come to use the term undisplaced as being synonymous for a fracture that can be treated non-operatively. But if we look at the literature, this may be less than 1 millimeter displacement, less than 1.5 millimeter displacement, less than 2 millimeter displacement. These are displaced fractures. They're either undisplaced or displaced. So the importance of a full information base when you're deciding whether or not to treat an undisplaced fracture non-operatively or operatively. We all forget about clinical examination. We focus on x-rays and CT scans. But if you see somebody acutely and they've got wrist swelling, perilunate tenderness, DRUJ pain and instability, there's going to be a lot more going on than a simple undisplaced fracture. And you will need to examine that wrist arthroscopically to understand the full extent of that injury. So our preferred treatment for so-called undisplaced scaphoid fractures, you only deviate the wrist to extend the scaphoid. You then dorsiflex and supinate to reduce the scaphoid and gain access for your wires and your screws. And here you can see an anti-rotation wire and a screw being inserted into the scaphoid. Now this can be done under local anesthetic and very quickly. Here's one without an anti-rotation K-wire. K-wire is inserted and we're using a power screwdriver simply to put the screw in. This is interesting. Watch how this carpus reduces as the scaphoid is fixed and the proximal pole is compressed on the distal pole. The image intensifier can be misleading. If there's any doubt, use the scope. Here you can see a wire protruding through the proximal pole of the scaphoid. You can withdraw it and look inside. 1 day post-surgery, you can start moving. They wear a splint for 6 weeks, a lightweight removable splint, but you can start supervised movement. Now this is case selection. Obviously, if you have a perilunate ligament injury or a distal radio-ulnar joint triangular fibrocartilage injury, you would not move them this way. So an undisplaced scaphoid fracture that I would consider managing in a splint. There is pain over the scaphoid, no swelling. The CT shows an undisplaced scaphoid. It's an adolescent with open growth plates. The importance of clinical examination, no perilunate tenderness, no swelling, just tenderness over the scaphoid. Treated in a splint, and as you'd expect, as Esther's told us, they unite very well. Now, this is what I would call a true undisplaced fracture of the scaphoid. This is an accurate use of the term. No wrist swelling, pain over the scaphoid, and you cannot see a fracture on the CT scan. But if we do an MRI scan, we can see a microtrabecular bruise focused on the scaphoid and to much lesser extent on the lunate and the capitate. So his sports physician says to him, "You can play football." So 3 weeks later, he hits a football and he presents with severe wrist pain and marked swelling. And now he has a transscaphoid perilunate fracture subluxation. And you can see just how unstable that is. That's that microtrabecular fracture that is literally broken with a relatively minor contact. The trick here is just to fix the lunate, the mid-carpal joint, and you can use the same technique. You fix the lunate, it becomes quite straightforward. 4 months later, he heals. So we still have a controversy. We have a microtrabecular fracture, truly undisplaced, and there still is a case for internal fixation. It's a choice that the patient makes with the surgeon. There's a risk-benefit ratio. And I'll put to you, if you have an elite athlete who is going to play in a grand final in 4 to 6 weeks with a microtrabecular fracture, there is a case to insert a screw. So look at this case. Swollen perilunate tenderness, distal radial ulnar joint laxity and pain. And if you look at that scaphoid, it's a proximal pole. There's no doubt, no controversy, that needs to be fixed. And you would say, yes, it's undisplaced. But if you look carefully, you can see a lucency at the fracture site and a minuscule avulsion fracture. You've got to look very, very carefully. So, you're thinking, we just got to make a cut on the back of the wrist, the dorsum of the wrist, drop a wire down and screw it. But I'm uncertain. We already know that it's swollen and there's a major wrist ligament injury. So should we use a scope? The answer is, I think yes, because it's about examination and information. And here you can see what appears to be unstable, a very unstable scaphoid. And furthermore, scapholunate instability. And to add to it, a positive hook test with an intact foveal insertion and distal radial ulnar joint instability. The foveal insertion was intact. I can't show you that. We haven't got time. So because we know the anatomy, we can do a dorsal distal peripheral repair of the triangular fibrocartilage and know we're going to get a good result. Then reduce the scaphoid. And here's the trick. You must see the wires come through the scaphoid because you cannot rely on the II, the fluoroscopy. You have to see the wires penetrate and then check that your fixation is solid. And that fixation in the scaphoid is not good enough without a radiolunate wire to hold the lunate and stabilize the proximal carpal row and the mid-carpal joint. But we still have a problem. We've got a radiolunate K-wire neutralizing our scaphoid fixation, but we still have scapholunate instability. So it's 6 weeks. Here you can see the X-ray. On CT scan, it's united. Take the wires out. The proximal pole is stable. And then we can do an arthroscopic dorsal capsulodesis, passing a suture over the scaphoid, then over the lunate. Using a dry technique, you get a tremendous view, and then getting a really good grasp on the dorsal capsule to close the dorsal ligaments over the scaphoid and the lunate. So in conclusion, we need more definition and clarity about what constitutes an undisplaced scaphoid fracture. We need to know whether there's an associated instability of the scaphoid or the wrist, the ligaments, and the DRUJ. We need to go back to basics and examine wrists, not just rely on an X-ray and a CT scan. The 1.9 millimeter arthroscope used dry is an excellent diagnostic tool. It gives you more information than an MRI or a CT scan. And once you know what you've got, it becomes a therapeutic tool. And of course, as Esther said, if you don't know how to do the surgery, you're going to have some complications. And I think a lot of the criticism of open surgery is on big series without people that are well trained to know what they're doing. So we need a full information base, and we must never forget that the scaphoid is part of the whole wrist. There's a choice and a decision to be made about surgery. There's a risk-benefit ratio. It's what the patient needs, and it's the expertise of the surgeon, the experience of the surgeon, and the facilities that are available. Thank you.